I think we've made great progress in all, I'd say all subsets of lymphoma. Notably, we've have new immunologic approaches to treatment that we dreamed of for many, many years, and we tried over and over again. There were so many investigators who spent their careers trying to harness the immune system. All we had really was an allo transplant, and that was appropriate for very few patients in general. But figuring out how to harness the immune system in many ways, so beginning CAR T, bispecific antibodies, and the PD-1 inhibitors. So lots of new therapies that have made a significant impact. Many of these first, of course, always have been used in previously treated, heavily pretreated in most instances, patients. And then we gradually move these treatments up. And right now we're in using these, or at least investigating the use of these novel therapies, either in combination or in place of conventional chemotherapy. So much has changed. This is a disease that there are two important aspects of the demographics. One is that these are, for the most part, teenagers and 20 and 30 somethings. So young people, even a single death is unacceptable. So we have a long way to go, although our survival rates are way up there of 90% or so in general. Every single life is a young life with the potential for many, many years of high quality life if we're able to treat effectively and minimize the long-term effects of our treatments, which is our biggest focus. But the other thing that's happened recently is we're seeing the frequency, the incidence of Hodgkin's lymphoma growing among the octogenarians, so very old men. The rate at which the Hodgkin's lymphoma incidence is growing is pretty substantial, and means that we're going to be looking at a large number of older patients for whom we need to devise therapies that are tolerable and effective. So optimizing means that we're not only increasing the effectiveness of our treatment, but at the same time reducing the long-term effects. And I think one story that was being told at our meeting was that there continues to be new information about long-term effects. And one of the most notable is the recent finding that patients treated with chemotherapy alone, anthracycline-containing regimens, have a increased risk of breast cancer that seems to be cumulative dose related. And this provides us with motivation to not only add new agents that increase the effectiveness of our treatments, but also to reduce the number of cycles of chemotherapy and the total dose of anthracycline that our patients receive. So we still have work to do. Well, I think the place where you need to address, the major issue we need to address, is the exposure to chemotherapy, and see if we can further shift from chemotherapy to immunotherapy. And so nivo-AVD is a combination of the two, but it's still a 6-cycle regimen. My own group, we've studied with some collaborators a regimen with an alternative PD-1 inhibitor, pembrolizumab, and that has in that regimen we're able to, at least in our first study, we're able to, from many patients, reduce the number of cycles of chemotherapy. And now we're trying in a subsequent trial to further shift from chemotherapy to immunotherapy. So I think that's where we're all going. We want to be able to give fewer cycles of chemotherapy to reduce the risk of breast cancer in young patients who are receiving an anthracycline. But also there are lots of other long-term effects of the chemotherapy component. And if we can further reduce that, perhaps get rid of it entirely, I think we will, our patients will really benefit.